Hey everyone, my name is Eric Norman, and welcome to the Flex Metal podcast. Shortly, I'll be joined here by Christian Jorns, physical therapist and co-founder of Flex Metal. Today, we're going to be talking about patellofemoral pain syndrome. We're going to be discussing and breaking down what's called the Clinical Practice Guideline to PFPS. We're going to kind of break it down and hopefully make it more relatable to individuals who might be having some of this knee pain or know someone who's having the knee pain, and hopefully you can take some good stuff away from that. So, as always, thank you for listening, and if you have any questions, feel free to reach out. Have a good day. Hey, Christian, what's going on, man?
Hey, things are great. This weekend, Victoria and I are watching our friend's dog. She's a 70-pound chocolate lab, about the same age as our dog Bruiser, and so they are constantly partners in crime, so we're just dealing with that. They might even come up here during this
Nice.
podcast and jump all over me, so we'll cross that bridge when we get there.
Yeah, there we go. We'll leave that in. We won't edit that out. We'll leave it in. And I tell you what, I just did a run. I did a run this morning, and I I hate whoever invented running. It sucks during the moment. I hate it. But not gonna lie though, 30-minute run, and if you want to trust an Apple Watch or not, said I burned over like 500 calories for a 30-minute run. I think that just goes to show how terrible my economy of running is. I just am laboring the entire 30 minutes. But no, now I feel pretty good though. So I think I might be running on a little bit of that runner's high. But
There you go. Next step is to get your Candy Cross harness like I've got and get a dog and
oh
do
yeah,
that. It's
there
way
you
more
go.
fun when your dog's having a good
Yeah,
time.
there we go. Nice, nice. Speaking of training and whatnot, how's your training life going? Any updates over there?
Yeah. I don't know how this happened, but like in the last week and a half or something, I got re-exposed to the snatch and clean and jerk, which I used to train. Like I trained that exclusively for 2 years in my mid-20s, like when I first got started into strength training, and I loved it. And I just like caught the bug. I just started snatching again, just started doing clean and jerks again. I got my lifters on. I've been looking at weightlifting barbells because right now I have the Rogue Ohio Power Bar. I've had it for 3 years now. I love it, but like that thing doesn't bend. It just doesn't spin nice. At least that's what I tell myself. So
Yeah,
I think I'm gonna wait for Rogue's uh, Black Friday sales because they often have their really nice barbells that have defects called the Boneyard bars for sale for like half price. So instead of being like 350 or 4, I can get it for 175. So we'll see where that takes me. But finishing up this training comment, my neck is so sore. I've been having headache. Like you forget how much that overhead work and all that like pulling and shrugging does to your traps and like your
yeah,
suboccipitals. And so I'm just all lit up. I can't really turn my head to the left very far right now without a lot of pain. So I'm just adjusting to these movements. And so I
yeah.
wrote a new program for Olympic weightlifting, and I think I'm just going to start doing that and like scrap everything I said the last couple podcasts for the lifting. It's been so much fun.
I love it. It is no, it is honestly. It's because it at least the way I look at it is it's a lot more technically challenging in terms of just like if I don't want to get ripped here if a power lifter listens to this, but like if I'm just doing like a bench press, right? I know that there's technical ways to be more efficient at it and whatnot. But when I look at a bench press, I just think like heavy weight down, heavy weight up. But when I'm doing like a clean or like a snatch, I'm like, I got all of like the triple extension in my head. I got like, bar path coming up and like my drop. And yeah, it's a great workout. And I feel like it's a little bit more stimulating when you're doing the Olympic lifts versus just like a power lift.
And also more frustrating and humbling when you have to bring your numbers way down and you still can't do the movement because you just don't have the technical prowess yet. Yeah.
Right. Absolutely. Yep.
And the last thing I wanted to say for an update is I finally got asked to be a musculoskeletal lab assistant at the University of New England. So I'll be doing that in the spring. Dude,
Nice.
6 years of asking. 8 years after graduating, they finally let me do it. So I'll be joining their team on Thursdays to help
Hell yeah.
instruct therapeutic exercise. I'm glad I got that day and not like the
Oh, dude.
modalities day. That I probably would have just said no
Yeah.
then.
Yeah. Yeah. Move on. Find someone else. Dude, that's awesome,
Yeah,
man.
thank you.
Congratulations. That's
It's
sweet.
gonna be fun.
Yeah.
Well, I know you said your running update already, but any other training updates or life?
I've been doing just a lot of work outside of my regular, 40-hour clinic job with our private practice and whatnot. And so I've been having some late nights in the old Anytime Fitness. Good thing it's anytime, so I can go there at 9 o'clock at night. But no, man, it's feeling good. Getting under some heavier weights, just doing lower reps. But it feels nice to be able to just start pounding that stuff out. But now you have me inspired to do some Olympic lifting, so we'll see we'll see where that goes. So anyway, well, let's get going into the podcast though, because we got a little bit of a doozy today, I think. So we're going to be talking about the Patellofemoral pain CPG, or the Clinical Practice Guideline. And before we dive into it for the podcast today, I'm going to let Christian just quickly review what the heck is a CPG, or Clinical Practice Guideline.
Yeah, so a CPG is really just like a master document that's written by a bunch of super smart people in the field that try to bring together all the best evidence that we have, plus expert opinion around a topic. And it'll cover everything from like risk factors, incidence, prevalence, how do you diagnose it, how do you treat it. So it's like almost like guidelines, as it says, for clinicians mainly to help treat people and get a lay of the land, but also for people who are interested in reading about it. It helps you understand like what your clinicians are probably doing, why they're doing that, all that kind of stuff. What's really cool about these CPGs is they basically rank things in a tier list. So they'll have grades of evidence for the recommendations, like grades A through F. So things that are grade A are more or less that you need to do these things if you're a clinician. They have tons of very high quality research supporting them, and they're just super valuable for almost everyone that has this condition. And then there's grades down to F, which are expert opinion. And I know that the letter F doesn't really sound good, but expert opinion isn't inherently bad. It just means that we don't have a ton of good evidence for it, but it still can be very useful when used appropriately for the right people, or at least just like give it a shot if you're really struggling with someone and you're doing all the other things in like the A, B, and C categories.
Right on, man. Yeah. I think you nailed it. And I agree with expert opinion. It sounds like they're giving it a failing grade, but it's not like one thing's, inherently bad. Like you think that, category A, for example, is like kind of the best evidence, right? So when you see something listed A, I want to later discuss something when it comes to interventions in that category that has very strong evidence with, and you're going to talk about how some things have strong evidence for to do, but some things also have really strong evidence not to do. And so it's a lot of times we think like, oh my gosh, this intervention has level A evidence, it must be really good. Well, sometimes it's level A evidence not to do it. So I'm looking forward to discuss that a little bit as well.
Yeah, so I think it'd be good just to get down to like, who is this happening to? What kind of people are experiencing this pain? And what really is it? So, Eric, what is patellofemoral pain syndrome?
So PFP, it's a diagnosis that we use in physical therapy in the orthopedic realm to describe this general, what we call peripatellar, which means around that kneecap, or retropatellar, or kind of behind the kneecap. Sometimes people might refer to it as like anterior knee pain, but it's a syndrome. So it's a collection of signs and symptoms around this retro or peripatellar knee pain. And it mostly, at least in my experience, I've seen it with adolescent individuals, younger adults, usually active. It can come on when you drastically change your training style. For example, cross country runners just getting into season, maybe running, 10 miles a week and now they're ramping up the next week to 30 miles and they triple their volume, right? I see it a lot with those individuals, just as an example. And so it's this, again, it's a collection of signs and symptoms, and it's almost a what we would call an exclusion criteria for diagnosis, right? Part of the diagnosis for PFP is you want to rule out other serious knee conditions, right? Meniscus, ACL, quadricep tendon sprain or strain, sorry. And so other things in that nature that we're going to exclude, okay, we know it's not that. And they're having this kind of ambiguous knee pain. And, we can discuss a little bit more of what symptoms they might feel, but they have these symptoms that we know are related to it. Overall, this sounds like a type of syndrome for patellofemoral pain. So that might be a little bit of a lengthier explanation of what PFP is, but hopefully that lays the land a little bit better for individuals.
No, I think that was great. Just like you said, diagnosis by exclusion. We look for everything else that could be causing your symptoms. And then if we don't find anything and you fit those criteria of the pain around the kneecap or pain behind the kneecap, and also just like what's causing your pain, it's almost always, and the CPG does say this, that the best tests we have for this are, do you have pain in that part of your knee when you squat, when you go down to a chair, when you go downstairs, when you're running? That's really the best that we can do to diagnose this. Again, after we rule out all those other things. And then,
Yep.
Yeah, I think I read in that CPG also that about 25% of front of the knee pain is due to patellofemoral pain syndrome. That sounds about right from what I see in the clinic. It just, now that I actually have a number to it, it makes a lot of sense. And you mentioned teens. Yeah. I definitely see it a lot in teenagers. And for them, I think it's exactly what you said. It's usually due to them doing too much like in totality, or too much too fast. When I see it in those older adults, it isn't usually them doing too much. It seems like they get it, honestly, because they're just not doing enough. They're just kind of weak. And when you get them a bit stronger, they tend to feel a little bit better.
I totally agree with all that. And I kind of want to use that as a kind of jumping point into the next thing I wanted to discuss relating to the CPG, was that they break down patellofemoral pain syndrome into 4 different categories for us, which I think is super useful in ways to try to identify kind of the main driver, so to speak, behind what is developing this knee pain. And so I think I'm just going to lay them out here quick and then we can discuss them. But so we have overuse or overload. And I think that's what we've been discussing when it comes to our teenagers that we see that have this, or athletic or active individuals, when they take on too much volume at one time. Next, I think you just hit on it, Christian, is muscle performance deficit, specifically in the hip and quadricep musculature. And like you said, you can see that in older individuals that just have a little bit of weakness going on there. And when you tend to give them exercises to make that stronger, they tend to feel better. And then movement coordination deficit, and then mobility impairment. So those 4 different categories. Christian, we already kind of talked about the overuse and the muscle performance deficit categories. Anything that stands out to you with the movement coordination or the mobility impairment that you think would be good to know for the listeners?
Yeah, so starting with the movement coordination deficits, that just means that there are certain movements that you can do, like for example, super flat feet, or your knee goes inward when you do a squat, or you go downstairs. Those are the things that they're talking about, just the control of your limb. Those things are weakly, and I mean weakly, associated with patellofemoral pain syndrome. And when you work on those things like on their own without other stuff, they don't seem to help people with this issue as much as you might think. And that just really comes down to what is really common across all of physical therapy, is that the biomechanics of your movement don't matter as much as we used to think, or like social media might lead you to believe. It tends to be those other things like overload, underload, weakness, that stuff. But I do think that if someone has patellofemoral pain syndrome, and they have a bunch of like knee caving in when they do stuff, and that knee caving in seems to hurt, and if you change that knee caving to make it happen less and they feel better, I think that's worth treating and worth incorporating into a more comprehensive plan, but it's more of a small add and a smaller consideration. And then to the mobility impairments, that's a fancy way to say that you're tight. So like we've looked at what happens if you have tight calves or ankles and tight quads, hamstrings, glutes, all that stuff. And the tightness really doesn't matter a whole lot. Sure, do people with tight quads feel a bit better in their PFPS when you stretch them? Yeah, that can happen. Do they need to stretch? Not everyone. Is it something you can add to someone's plan again as like a smaller contributor to the overall plan? Absolutely. It's not harmful. If you want to stretch, go ahead. It may help some with the symptoms in the short term, but it's certainly not going to cure you.
Yeah, really well put. I like how you touched on the movement coordination deficit. I think it's very easy to get into that trap sometimes. Like you mentioned, how throughout the entire human body, we see in different joints how, the kinesiology or the movement of certain joints is maybe not as important, I guess, as we originally were led to believe or believe now. It's a very easy way, I think, for individuals to sound smart on social media and put out some really cool videos. And I look, I mean, it's like you said, if it feels better when you correct it, and if you're having maybe some visually, it looks like you're having some greater knee caving in, what we call valgus, or whatever it is, and it feels better with that. And that's just at the end of the day, it's like activity modification of how you're doing something. And I think we can get really lost or sucked into that trap of this movement coordination, when in reality I would say that overuse overload is by far number one, muscle performance deficit number two, and then yeah, that movement coordination and the mobility impairments, they're there, but I would argue that they're just not as significant or beneficial to focus on compared to the first two.
Yeah, and even when you go back to those four different groups themselves, they in the CPG they even give certain components of those four things letter grades. And so like the
Hmm.
muscle performance deficits or like your strength endurance, those have grade A evidence to supporting that you should be strengthening key areas of your body, which I'm sure we'll get into in a bit. And then for the
Yep.
stretching, for example, that has grade F. Like we really don't have strong research evidence for it, but expert opinion and anecdotally, you give someone a quad stretch, for example, they might feel a bit better. Now, the one that's a little bit
Hmm.
weird to me, which makes some sense, I guess, is that the activity modification only has a grade F, which means that like we don't have
Yeah.
super strong evidence for it. But I think that's mainly because it's really hard to study. And it's really hard to study because if you have a runner with PFPS, which is again also called runner's knee, you're going to be giving, if you had 100 runners of various ages, even the same age, honestly, you're going to be giving them all a little bit of a different plan. So it's hard to be super consistent in a study when you're giving personalized, individualized advice.
Yeah. Yeah, I agree completely on that. And when I was reading through this, I took one of these interventions a little personally. I don't know if you're gonna know which one I'm gonna talk about. For individuals that really like dry needling, I hate to break it to you, but dry needling, level A evidence, very good evidence that we should not dry needle for treatment with individuals with PFPS. So,
I mean, you're a
ouch.
needler and I'm a joint cracker, and they say don't do joint cracking either. And it's like I really
That's
wouldn't
true.
anyways. I'm
Yeah,
not going to crack your low back to
yeah,
make your knee pain better, unless it's coming from your back. But even then,
yeah,
yeah. So really, it just comes down to what we
yeah.
said. It's that activity modification. It's that exercise. Maybe throw in a dash of stretching, and there's some other stuff that we could always talk about too.
Yep. I thought it was interesting. Foot orthoses that had level A evidence to prescribe foot orthoses, and I mean the CPG. I mean we won't have to get into it too much here because there's one thing I really want to discuss next. And I know that we're keeping this to a certain time limit, but they do discuss how they discuss the like more distal and proximal. And for individuals that might not know those terms, distal means kind of further away in the extremity, so that's like hand and foot, whereas proximal is further up in the extremity, kind of closer to your torso. So that'd be like shoulder and hip. And they discuss how distal and proximal findings can affect the knee pain within the CPG, and they give foot orthoses a level A evidence. Clinicians should prescribe prefabricated foot orthoses for patients with greater than normal pronation, which just means certain positioning of the foot to reduce pain, but only in the short term, so up to 6 weeks. So I thought that was an interesting recommendation as well.
Yep, I can't say I do that one very often, but I certainly have. And it can be helpful, kind of like when you give anyone the recommendation for foot orthoses. We don't know if it's really going to help you. It's not super convincing evidence on those things for most conditions, but it's certainly a low cost intervention. If you don't get custom, of course, which you don't really need custom almost never.
Mm-hmm.
And so definitely worth trying if you're having this problem.
Yep, I agree. All right. So the one of the things I want to hit on, this might actually be my last. Nope, just kidding. Two things I have for you, Christian, and then we can go from there. But I want to get your take on some statistics from two studies that I was reading through in the CPG. So one of the studies in the CPG looked at only 54 adolescent girls. I mean, take it as you will. 94% still had knee pain at 4-year follow-up. At a 14 to 22-year follow-up, only 22% of these 54 adolescent females ended up with no knee pain, with 71% having less pain. What do you make of those statistics and percentages with this knee pain in those individuals?
Yeah, I was thinking the exact same question for you because I noticed that they threw out the number 70 to 90% of people with this kind of condition end up having recurring symptoms. And this is like a whole separate podcast, maybe even like a series of podcasts on differences between gender and cultural issues related to like how we encourage boys versus girls to move and to be stronger and what kind of sports they play and all these different things. So my answer is really, I don't know exactly. I just know that we have a bunch of different things that we're paying attention to, kind of like what I said. And it does seem to be that women have more issues with this condition. And, some things that people think about are that women just don't engage in strength training as early as boys do, or they don't move as well or efficiently as boys do all the time because they're not encouraged to do so from a very young age. You don't have as much exposure to that. Culturally, that's an issue. Possibly. And also there's like some biomechanical thoughts around they just have different shaped pelvises and joint angles and all that. And that can lead to them putting different stresses at their knees, which can cause this issue a bit more often. And it's also just one of those things where like low back pain or tennis elbow or something, once you have a condition, you're more likely to have it again. And that's just for, again, a whole different podcast. So many reasons for that. But, as a personal story, I had PFPS for as far back as I can recall in football when I was a little kid. And then again in volleyball in high school and track and cross country in high school. Like I wore knee sleeves all the time. And there's actually, I forget what grade evidence, but really high grade evidence that said you shouldn't wear any braces or knee sleeves for this thing.
At level A.
Okay, yeah.
But, level A for no knee braces.
We didn't know that in the 90s. So I wore them, and I don't know if they did anything, but eventually the pain went away. But then once I got more into strength training in my mid-20s, the pain came back. I had that like searing, sharp pain behind my kneecap, felt it in my squat, felt it going downstairs. I just adjusted how much I was doing, my dosage, and even added in some more movement variety, and things began to feel a bit better. I even had my most recent bout of this. I think it was 3 or 4 weeks ago. I was having some of that sharp pain behind my knee. I just adjusted, and now it's gone again. But yeah, so I don't know if you had any other thoughts. I know that wasn't like a super specific answer to what you asked, but it's so hard.
Yeah. No, I thought that was good. And I'm giving you thumbs up over here inadvertently. I didn't know I was doing that as we were discussing. I think I might have mentioned this in the previous podcast, but I just want to reiterate it because I don't know if it's appropriate to think like this. So treading with caution. But in one of the monographs for the OCS for low back pain, they discussed the idea of treating low back pain with physical therapy, and really kind of any type of rehab intervention that we treat low back pain as more of a kind of like a tune-up session versus a complete cure, right? Because we know that the prevalence rate of recurrence in low back pain is quite high. I want to say around like 60%. And then, same thing in these statistics that we see in the CPG, that the recurrence rate of knee pain is pretty is pretty high. And you just mentioned yourself, Christian, when you get it back, you kind of go back to what you know works. And so I almost want to say, do we treat this kind of like low back pain? Do we treat a lot of things in the human body when it comes to physical therapy like low back pain, in the sense of, you know, we're not necessarily curing your pain and it's going to be gone forever. It can come back, but if it does come back, we have the knowledge and the resources that hopefully we can equip the patients with to know how to handle these flare-ups independently. So it's more of a tune-up session, bring your car into the auto body shop to get the oil change, etc., versus this cure-all plan of care.
Yeah, totally. I think that is a good way to be thinking about this. But, that's really not sexy. It's really hard to sell to a patient. Everyone wants that cure
Yeah.
instantly. And some folks are going to be okay with what you said or what I said. And that honestly is the truth. That's the way it's going to shake out. Like, I'm sorry. But some folks are
Yep.
just not. And they're going to be chasing those instant cures. They're going to go get their knee taped. They're going to get their orthoses. They're going to get chiropractic adjustments, and they're going to hope for the best. And maybe it'll work, but are those things actually working? Or was you just changing your behavior over that whole period of time when you're trying all this different stuff actually what helped you? I don't really know.
Absolutely.
But we do know what you should be
Yep.
trying to do. And that's a good segue for what do we do about this? Like, how do you,
Yeah.
Eric, how do you approach treating PFPS?
Yeah. So it's definitely individualized for each one, right? And I say individualized more in terms of most of the time we're doing some sort of activity modification. And it depends on what your daily lifestyle is and what your activities outside of those daily lifestyle things are. What sports you play, how you train, your hobbies and all that stuff. Based on those things, the aspects of your case, we're going to probably activity modify some of these different things. Most of the time, when I see someone with this PFPS, we usually find one or two points throughout the lower extremity that we would consider, weak. So we're usually doing some type of strength training for that. Especially if it's adolescent, we'll take a look at some flexibility tests and get a sense of, like, does testing your hip flexors feel really tight in this position? Does your hamstrings feel really tight? How's your, what's called your closed chain dorsiflexion? I like to really look at that as well. And if there's anything in there that's pretty apparently positive, we'll go after that as well. I like to do those as the first line of defense, is the activity modification. Pain education is another big thing. So educating the patient on what their pain is and what's going on. And then therapeutic exercise in the form of flexibility training and strength training. And if those things aren't quite taking us or putting us on the right path to get to where they want to be, and then maybe we'll throw in some different things, like if it is, patellar taping, there's a B level evidence for patellar taping that clinicians may use tailored patellar taping to help this. And then other types of combined interventions, like there's an expert opinion on blood flow restriction around PFPS. And so, it's more of a, this is what we know is going to work, so we're going to start with this and make you very independent with this. If we're still not getting to that finish line like we want to, and then we'll sprinkle in some other stuff as well.
Yeah, sounds great. I think of this as, and this is what I tell my students, maybe not you, but I tell my students now, a lot of these conditions, it's like a do less, do more, or do different. So maybe you're doing too much. We got to pull back. You are just doing more than your knee can recover from, and it's getting sensitive. It's getting sore. You're not damaging stuff. It just doesn't like it. So, like, stop, pull back a little bit, reset, find what you can do, build back up, whether that's running, that's squatting, that's cycling. I don't care what it is. It's just that concept works really well for a lot of people. Or maybe oftentimes in some of those weaker, younger athletes or like weaker, older folks, they need to do more. They need to do not more of the activity that's hurting, but more just general strength training. We know that according to the CPG that we need to do like hip and especially quad strength training. Those are the two heavy hitters. And so we do a bunch of that, get them quite a bit stronger over a long period of time. They tend to feel a lot better. And then also do different. The CPG said earlier that single sport athletes have a higher risk of this. Multi-sport athletes have a lower risk. And we see that for just injuries all across the body, in that the more you do the same thing over and over again without adding in more variety or doing different, the higher your injury risk is, the worse you're going to feel, because you just keep stressing those same exact parts of your body in the same ways over and over again. And it needs to be, you need to chill out, just do something different. And so I like to combine those three different things, and more often than not, that approach works pretty well.
Yeah. Yeah. You stole that point from me, by the way. I was going to bring up the single versus multi-sport
Oh, nice.
athletes. But I got one more point I wanted to bring up, and I don't think we'll dive into this one completely, but I think it's good just to bring up, and this might be a good one to end on. So psychological risk factors. Within the CPG, they reference a systematic review, which a systematic review is just a review of studies. It's a study that's a review of studies, right? So within this systematic review, there's 25 research studies, over 1,300 patients. And they found that factors such as depression and anxiety, pain catastrophizing, fear of movement may be causing elevated risk factors for patellofemoral pain syndrome, and likely have increased pain and reduced function for those individuals who do have PFPS that have these different risk factors. In general, Christian, your thoughts on psychological risk factors we'll just keep it to PFPS.
I was going to try to make a link to like low back pain or whatever, but I guess I won't. I don't really think about that often for PFPS.
Yeah.
I don't know if that's just like I got blinders on for some reason, but I'm sure that when it has come up in the past, I've addressed it. But absolutely, if you are super worried about your pain, or you think that the pain you're having is super damaging and like you're never going to get better, you're afraid to move, you avoid moving because you're worried about getting hurt or you're worried about the pain, that stuff is not constructive. And we don't fully understand all the reasons why those types of things contribute to your pain. We just know that they do. And we know that when you work on improving them, decreasing your anxiety, decreasing your stress, being more confident in your movement, increasing your self-efficacy, like your belief in yourself to be able to accomplish something, you do all those things, you generally get better. And I know you said just keep it to the knee, but that's for every part of your body. Like you got to be, that's why we have flexed metal as our name. It's all about resilience and self-efficacy. You need to be proud of the work that you're doing, be proud of the resilience that you've built, and handle those problems in a spirited way, because when you do that and you live that, your life is so much better. And I don't want to end on that one. I actually want to end on one other thing, which is practical advice for people if they wanted to try to construct an exercise plan for themselves, or like just think about what they're doing for their own treatment with their physical therapist or their trainer for this issue. So I know this list could go anywhere, but Eric, what are some of your go-to exercises when you're treating folks with this condition?
Yeah. So one of the first things I like to do, and this is kind of going back to the previous point of psychological risk factors, especially if someone has fear of movement or they have a tendency to pain catastrophize. What I'll do is I'll take them through range of motion in different ways. With open chain, where that foot isn't planted on a firm surface, or closed chain where it is, so that could be in the form of like a wall squat or something. And I'll do it within a pain-free range, just to get the individual there, just so their brain can see, well, I can move this knee and do these different things lying down, standing, sitting, etc., and I don't have pain with it. Like, hey, this is possible. We can make this type of recovery. So that's one of the first things I'll give them, is just to show them that they can move the knee and it's okay. And then one of my go-to exercises, you mentioned quad and hip musculature. So for me, quadriceps, I like to do eccentric knee extensions. And what that means is eccentric is doing, you're focusing on the movement on kind of the down phase of that foot, right? So when you kick the foot up against weight and you straighten the knee out, that's called concentric. And then the eccentric is when you're bringing that foot back down and the knee is flexing. I like to focus on that eccentric, or that lowering of the foot, because when we look at symptoms within the diagnostic category, going downstairs is a main pain provocator, provoking your pain. There we go. We'll just say that is one of the main symptoms for that. And that's all about that eccentric loading, or that eccentric control down the step, using a lot of those quadriceps. So one of my other go-to exercises, eccentric knee extensions, I think it works quite a bit. And the other thing too, patients can really feel that. And so they really feel like, oh my God, I'm doing some really great work here. My knee must be, making good strides, because this exercise is, I can really feel it in that thigh.
Yeah, I mean, totally. I'm glad you brought up knee extensions or quad extensions because I use them all the time if people have gym access. No one has one of those at home, but
Mm.
if they have a gym membership, I always get them on the knee extension machine. Maybe as like their second or third exercise. Usually I'll try to start with some of the heavier hitters in closed chain, like some kind of a squat pattern. Maybe it's the wall squat or a wall sit, or it's a full range of motion goblet squat, whatever it is. Guys do that. I also do single leg, right? Like I'm going to do some kind of a step up or step down pattern, like you said, maybe a split
Hmm.
squat, maybe a forward lunge, maybe a Peterson squat, whatever it is. I'm getting them doing something like that. And one other thing I wanted to bring up
No,
about this. Oh yeah, go ahead.
I didn't mean the thumbs down. My camera gave a thumbs down, and I'm not disagreeing with what you're saying. I think what you're saying is great. I got to keep my hands down. I keep giving the wrong signals.
Okay, so one other thing I wanted to say about this was I find it, and this is, I don't know if this was really in the CPG, but this is definitely one of those like expert opinion, anecdotal things, is people really find that training through a partial range of motion or training to that edge of their knee pain is super helpful in this condition, because going through it over and over again, like if you hurt in the middle of that downward portion of the stair or like that leg extension, it often just feels like crap. So if you just do part of the range and then you just build on that, and over a handful of weeks, you'll find that that range starts to improve over time and you get farther through it. And so going to that edge is really helpful for this, which is unlike if I had someone with a quadriceps tendinopathy or patellar tendinopathy, where even if they have pain, I'm really going to try to go through that full range of motion with pain, because that generally works a lot better. And I'm not worried about that pain getting worse with this condition, usually.
Nice. I like it. I think that's a great point to end on. Very practical things that individuals can take right now. If you're feeling this type of discomfort, or if you know someone who's feeling this type of discomfort, or if you're a clinician or some type of individual that's working with someone with knee pain and you want different ideas, hopefully some of those ideas might, help further that plan of care for you. So no, I think that's a great point to end on there, Christian. Any other last words? Otherwise, I think we covered this CPG pretty well.
No, I'm all good. Thank you.
Awesome, yeah. Thank you as well. And if anyone has any questions or comments, anything like that, feel free to reach out to us. And then don't forget to go on a YouTube page. We have our contact information there, or social media, and you can find a bunch of other good stuff, other parts of the body. So, all right, Christian. Well, we'll see you next time. Thanks so much, man.
Yep. See ya.